My name is Ebony Amaro, and my category is cervical length and Bishop score. So, a quick introduction to both exams or tests is that cervical length measures the cervical length by a transvaginal ultrasound to assess risk of preterm birth. And the Bishop score is a scoring system that assesses cervical readiness for labor induction. You have to excuse my little one in the background. A description of both tests is that a cervical length measurement measures the length of the cervix and it's measured in millimeters. Of course, like I mentioned, using transvaginal ultrasound. And a Bishop score is a digital exam, which means by using your fingers to score dilation, effacement, station, consistency, and the position. The history of the cervical length measurement was studied extensively in the 1990s for preterm birth prediction. So this has not been going on as long as many may think. Um, so just about maybe 30, almost 40 years ago is when we started actually measuring the cervix and understanding what the measurements mean, as in for risk for preterm labor. The Bishop score was developed by Edward Bishop in 1964. So we've been using the Bishop score for quite a while. The current recommendations for measuring cervical length is that we measure the cervical length by ultrasound between week 16 and 24 of gestation to assess the risk for a spontaneous preterm birth. This is really important for women with a history of preterm birth so we can prevent it from happening. And if you have a short cervix, which is a measurement of less than or equal to 25 millimeters, that means you're at increased risk of a spontaneous preterm birth. It's not 100% that a woman will go into preterm labor with a short cervix, but that just means they have an increased risk. The treatment is vaginal progesterone, or in more intense cases, a cerclage. The Bishop score was used before induction to assess cervical favorability and whether or not cervical ripening is needed. For cervical length, less than 25 millimeters before 24 weeks is going to be linked to higher preterm birth risk. We need that cervix to be long because it shows that it has a strong structure. If it is shorter, then you may have structural weakness in the cervix that can't hold up the weight or the pressure of a growing fetus. The Bishop score, a score that is greater than or equal to 8, predicts a successful induction. That means the cervix is ready um, to be opened and ready for labor induction. Indications for cervical length measurement is a history of preterm birth, preterm labor symptoms as well. And for Bishop score, a planned induction of labor, automatically we do a Bishop score measurement. For both exams, contraindications are if there's a high risk of hemorrhage, if there is a risk of infection introduction, so introducing infection to the fetus, of course, and then if the exam won't change the management. The patient does not consent, we don't do anything. That's gonna forever be a thing. If the patient does not consent, we will not do it. These should also be avoided if maternal fetal instability outweighs the clinical benefit of the exam. Okay, so for measuring cervical length, first the patient will empty their bladder. They'll be positioned in dorsal lithotomy. A sterile lubricated probe is then inserted into the vagina. And then a sagittal view is going to be used to identify the cervix, and then it's going to be measured from the internal os to the external os. We also will assess for funneling or changes with pressure. Funneling is usually if the cervix creates like a V shape internally, and then we'll put pressure on the cervix to see what changes are made. Again, we are checking the structural foundation of the cervix. The Bishop score first, same thing. Patient will be Position in lithotomy or modified dorsal position. Sterile lubricated gloves are going to be applied. Two fingers are going to be inserted into the vagina to reach the cervix. Then we'll assess the dilation, which is how far open the cervix is, the effacement, which is how thin it is, fetal station, which is how far up or down the fetus is, the position of the fetus in the pelvic cavity, the cervical consistency, I'm sorry, whether it's firm, medium, or soft, and the cervical position. We'll assign points for each based off of the chart that was shown in the previous slides, and then gather the total points for a score. Advantages and disadvantages of both. Advantages of measuring the cervical length is that it is objective, not subjective, and it's accurate. So we can measure it and we'll know that that is the length that we have. Disadvantages is that it does require an invasive, semi-invasive procedure, which is the transvaginal ultrasound. For the Bishop score, advantages are that it's quick and low cost, quick digital exam. And disadvantages is that there is examiner variability. So one examiner can come through and give you a measurement, but another examiner can come through and they may feel different and it could vary. Okay. Abnormal findings with checking for cervical length is that um, the measurement is short or low, which is less than 25 millimeters before 24 weeks. This indicates increased risk of spontaneous preterm birth, premature rupture of the membranes, preterm premature rupture of the membranes, second trimester loss, funneling. Funneling, like I said, that's a V shape in the cervix, and that indicates cervical weakness or insufficiency. Both of these things they indicate an increased risk for spontaneous labor because, once again, structural insufficiency of the cervix to hold up the pressure of a growing fetus. The Bishop score, a score that is greater than or equal to 8 early in pregnancy or without a labor plan, may indicate preterm cervical change, preterm labor risk. A score that is less than or equal to 5 shows an unfavorable cervix. This this leads to high likelihood of a failed induction, prolonged labor, or increased cesarean risk. For follow-ups, following up for cervical length that is less than 25 millimeters before 24 weeks, the recommendation is to start vaginal progesterone, increase surveillance, educate on signs of preterm labor, and possible activity modification. Less than 10 to 15 millimeters, may want to consider a cervical cerclage, which is when we'll put in a few sutures into the cervix to make sure that we don't have any extreme dilation or changes. Impossible hospitalizations or close outpatient monitoring, or fetal fibronectin therapy testing if symptomatic. Once again, a short cervix does not mean that you're 100% going to have preterm labor, but increased risk. For the Bishop score, an unfavorable cervix, which is a score of less than or equal to 5, you'll use cervical ripening agents such as prostaglandins, mechanical dilators, like a Foley balloon, or will delay the induction if it's not urgent and the baby does not need to be born right away. A moderate score of 6 to 7, you may proceed with induction. You just have to use caution and consider ripening agents just to help the cervix out a little bit and make it more prepared for labor. A favorable cervix, which is greater than or equal to 8, you'll proceed with the planned induction and monitor the labor progress. And if there's an unexpected high score early in pregnancy, which means that cervix is ripe, thin, probably have some dilation, and it's early in pregnancy, of course, that is a red flag, and we will evaluate for preterm labor and monitor contractions and cervical change. What we'll teach the client is that their cervical length will explain to them the importance of it and the structural importance of having an adequate cervical length. Treatments that can help a short cervix if needed, teach the warning signs of preterm labor, will review medications with them, and will reassure that many women with a short cervix will continue to have a healthy pregnancy because every pregnancy is going to be different. A woman may have a short pregnancy or a short cervix in one pregnancy, but then the next pregnancy go on and have a sufficient cervix. For the Bishop score, we'll explain induction readiness and we'll also let them know what to expect during the exam. If they're experiencing regular painful contractions or vaginal bleeding, then they need to let the provider know. And here are my references. Thank you so much.